have been asked to come here today because you guys are actually doing something in the United States that I think maybe you're one or two states that is doing it right now. Community medicine. I'm from Raleigh, North Carolina, and nobody has heard of this program. And this training is for you. So if I go too fast, if I'm not answering your questions, if you have questions, we will take questions during the session if you'd like. If it gets to be too much, I'll ask to hold till the very end. So over the agenda today, so basically every time that you see a patient, you code the service using an INM code, which is Evaluation and Management Services. There's many types of evaluation and management, which you're probably all familiar with. Office, hospital, ED, observation, home visits, skilled nursing facilities, all of those are evaluation and management codes. Documentation, we'll review documentation that when you are seeing the patient that your evaluation and management code documentation is supported. Procedures, you do a lot of procedures. Sutures, repairs, EKGs, a lot of catheters are going on. And then selecting the correct CPT ICD-10 to report on the claim. So when you are seeing a patient and you report a claim, that piece of paper going to the insurance company needs to tell the story of what you did with the patient. I call it paint the picture of what you did to the patient. So when that claim gets to the insurance company, they know exactly the acuity of the patient, exactly what you did, the risk of the patient, and they can pretty much tell next step as well, believe it or not, from your documentation. So you use the system called MediTouch. You're going to have to figure out a way to distinguish between new and established patients. So obviously a new patient to a medical provider is any patient that you have not seen in 3 years at any location. Any location. I like to use the example, if for some reason you have to see me today and transport me, and then all of a sudden I go back to North Carolina and Char happens to come to North Carolina as well. And she also has to come get me again. She will still report me as an established patient because we have already established a relationship. So the tax ID has nothing to do with new versus established, okay? Now, with that being said, if Char sees me today and tomorrow you come and see me, I'm still established because since you are all under one tax ID, you act as a group, okay? So we see Yvonne Russell today. You're going to document my note. I'm under the assumption that in like say 3 weeks that you come to my house to follow up. If you pull my name up in MediTouch, there will be a note for the other provider to see that I have received services from this organization previously. Is that correct? So that would be your cue as providers that that second visit now will be reported established, okay? So if you see me in the hospital and you're coming to follow up on me the next day, that second visit is established. So the next few slides are fairly easy. They're evaluation and management codes. I handed out this beautiful little handout. This handout is an auditing format. I should have said this in the very beginning. I am trained by a physician, Lynn Myers, who's internal medicine, is a consultant for me. If you were to call and ask me a question about a patient that I cannot answer because I am not clinically trained, I call Dr. Myers or I'll text her and she'll email me right back, or I'll say, hey, I have a provider here. I cannot answer her question. She would do that. So please know that because I'm not clinically trained that you do have an MD behind me at all times, okay? So when Dr. Myers does these presentations, she tells providers, whether you like it or not, your documentation is not for the provider coming in behind you, it's coming for the auditor. You didn't go to medical school, you didn't go to school for 6, 8, 10 years, whatever it to be, to learn how to code, right? Well, the reality is you're gonna have to learn how to code. But that's why you have Intermedix, that's why you have me. It's very easy. The great point for providers is everything that you do is based on risk. Your overall code selection is based on the risk of the patient. Your medical decision making, your cognitive labor is what I call it, is what you are paid for. and your time, but cognitive labor is what you are paid for. So when you're evaluating a patient, you are thinking, okay, do I need to transport? Is this an MI? Whatever it may be, you're thinking that. And if you don't transport, what would be the repercussions of not transportation? Is that a good way to explain it? So that criteria will always be their overarching criteria. All right, any questions so far?
So I just want clarification. We were kind of told you never really bill out more than a level 3 in this setting because of the acuity of the patient. So it's not based on the acuity, it's based on the risk.
Well, acuity and risk goes hand in hand, absolutely. So back pain is the most common call that is received that you go out to. In my mind, is back pain considered self-limited to all of y'all? Does back pain go away on its own sometimes?
Yes.
Right. Sometimes, and what else? Sometimes if it doesn't, what happens?
You have to worry about chronic cleanup.
Exactly, what else?
Dural access.
Yep, exactly. What's all that lead to? Probably surgery?
Permanent impairment.
You got it. That's what I wanted you to say. So now, is that back pain self-limited? No. Did you as providers have to think about all of that when you're evaluating the patient? Absolutely. You're taking all components into consideration, including their history, their past medical social history, if their past medical includes drug use. So you're taking all that into consideration for your risk. And obviously it's an injury that changes everything. Okay, perfect. So that's where the history comes into. So that for that back pain patient, I want you to tell me everything you know about the patient with the back pain. How long have they had it? Are they on medications? Was the first initial back pain from an injury? How did it start? The occurrence, frequency, all of that tells an auditor a lot. It also tells you a lot, okay? So the chief complaint will be back pain. You always have to have a chief complaint in a medical record. The chief complaint absolutely is required. It sets the medical necessity, okay? I used real live examples from your medical records. On one of your patient was feeling unwell, muscle cramping. That is fine. I notice as you go in, you start in your subjective, you type more information, which is great, which is your history of present illness. The location, quality, timing, severity, these are all elements of history of present illness. I would like to say modifying factors are very, very important. If they use ice, heat, whatever that they use, don't forget that modifying factors are just not medications. A lot of providers just feel that a modifying factor is medications. It is not. It's anything that relieves or worsens the condition. Okay? So review of systems. So I asked the question, when they record the review of systems, do they typically ask 10 review of systems, or do they do 5, 2, and typically the answer is they do 50 based on the acuity of the problem. So she said that if the patient has ear pain, she is not going to ask GU for an ear pain patient, which absolutely makes sense. In all of today when I am training, think back that when you walk into an encounter with a patient, that you already know the acuity of the patient. As soon as you walk on the scene, you know exactly probably what you're going to code. Back into the documentation. Let's say that the patient does have ear pain, but all of a sudden she gets in there and it's ruptured. That patient does have hearing loss, the whole 9 yards. Now we're not just an easy one. Now the acuity just went up. For her to build a higher level of service, she's going to need more review of systems. So just keep that in mind, that if you're going to build a higher level code of service, you're going to need to back into your review of systems. 9 times out of 10, the patient will tell you these. I've never been in one of your scenarios. I shadow providers all the time, but I've been in exam rooms where they come in for just ear pain or back pain, and they'll say, oh, by the way, I have this little mark on my ankle. Can you take a look at it? And then my elbow's been hurting me lately. They are telling you a lot of information. And while you're documenting, you may not be paying attention, but now pay attention. That's them giving you their review of systems. Does that happen a lot in your encounters? Okay, perfect. So just just because you do not ask, if they volunteer the information, that does count. Document it, okay? Past medical social history, most important piece, in my opinion, as an auditor. Reviewing all of your records, your social history is almost non-existent. When the auditors were picking your levels of service, We have medical is perfect. Social and family is almost non-existent. How my auditor supported some of your levels of service is they could see that the patient smoked, was drinking, and drug use. So we can take all of that. So they were giving you a point for that. When you were taking your HPI and the husband states, we use that as marital status. So we can pick parts out of it. What you don't want to do is make your auditor work for the information to support your level of service. So, and that social history, you can see who they're with. You can just add, it's literally 3 or 4 words that will get you a complete review of, a complete past family social history, okay? Excellent question. So her question was, when she's seen a pediatric patient, they don't have family history. They don't have, obviously, they'll have social history, but their medical history is pretty non-existent. She's absolutely correct. You will put no pertinent past medical history and you will get full credit for that. But you have to click it, okay? So I think we did look in MediaTouch yesterday. Almost in every EHR system, if there's a button, you have to click it. As a medical provider, if you bypass that, the auditor cannot give you any credit for it. And one thing that I need to do to put on my to-do list for your organization is I need to see that once on past family social history, some EHRs will put above reviewed by the provider and your name will go there and you will get full credit for that system. And then some do not. So Shar, will you put on my to-do list to check to see if MediaTouch does that for me, please? It does not? Okay. So then I will, after today, I will also do a little highlight bullet point and I will add something to that. Okay? Great question. Any other questions? You're absolutely right. And when they do not know, you are absolutely to document. Patient does not know. Whoever the historian is giving the information does not have the information. Okay, you do get credit for that. We were talking about if a patient is intubated, obviously they cannot give you any of this. So you would, so you would get full credit for that. If a patient there's a few cases where the patient had severe dementia, but there was an historian at the site, was like a husband or a wife, and they were able to fill in the blanks. Unfortunately, I cannot give you a complete history for that unless you tell me the husband also has dementia. Okay, so just keep that in mind. But if the patient is incoherent, intubated, and there's no other historian, you automatically will get you'll get credit for that entire section, but you need to document. So we're going to get to your examination. There's 2 guidelines. There's 97 guidelines and 95 guidelines. Obviously, 95 guidelines came first. The specialist got all upset and said, well, if I am orthopedist, I'm never going to examine GU, which would make sense, correct? So they came out with 97 guidelines. As an auditor, I put 97 as heaven. I use 97 guidelines to audit. It's easier for me. As an auditor, when you're audited, the auditor is going to pick whatever guideline to get you the service that you reported to support it. So are you familiar with which guidelines you use, or you just document and don't worry about it?
Don't worry about it.
And that's fine. So that's why I passed this out. In MediaTouch, the E&M calculator, does it count exam elements? Perfect. So it's counting for you. So you don't really need to worry about that. But I have to say this as an auditor, do not always count on your E&M calculator. The E&M calculator is a machine. It is a computer. It cannot measure your medical decision making. So while you use your calculator as a backup, absolutely do not use it as the ultimate code selection, okay? Use it as a tool to guide you, okay? So medical decision making is based on 4 elements. We have straightforward. Straightforward to me is if you get called and a patient has a mosquito bite and you said, yep, it's a mosquito bite, don't worry about it. Scratch it when it's itchy, see you later. That is straightforward, okay? Straightforward is self-limited. Low complexity is also self-limited in certain situations. Low complexity to me would be otitis media. Here's some amoxicillin, follow up with your PCP, okay? Back pain, take some Tylenol, follow up with your PCP, okay? Going back to the back pain, we'll talk about when you start injecting and giving Toradol, et cetera, because that is no longer low complexity, so let's keep that in mind. Moderate complexity. Based on what I am seeing on your audits right now, I'm going to guess that you're probably going to be about 60 to 70% moderate complexity, and the rest will be high. And your high could even be higher. I only have one audit right now, and since you're not really coding for reimbursement purposes, I think that the reporting is not accurate. Your documentation is perfect, but what you're selecting is you're just going along with the strides right now, which is absolutely fine. Okay? So moderate complexity is anything that is mildly exacerbated. It's an acute illness or injury. High complexity, self-explanatory, I would believe. Those high complexities are your patients that you are absolutely taking straight to the ER. And some of your moderates as well. So I'll use patient's COPD. You're going in and giving a neb treatment, and you can't get their pulse ox up. You have to transport. Even though he may be mildly exacerbated, you still can't get him clear, and he's still crackling and wheezing. As clinicians, you get to tell me if it's a mild or a severe exacerbation. Either way, he's going to the ER, okay? Same thing if I go back to your patient with the same COPD and you give 2 nebs, pulse ox is still at 82. He is going to get transported as well. So keep that in mind. That was probably a pretty gray area how I just explained that. Would you agree? The reason why I use that example, it's all in your documentation. If you tell me that the patient is mild, I'm going to sign moderate. If you tell me that he's severely exacerbated, I'm going to sign you high. It's all in how you tell me the patient. Paint the picture of how sick the patient is.
So the higher the complexity, the higher the E&M code can be justified.
Absolutely. Absolutely. All right, so then I just broke it down in your medical decision making. I'll go back to Char's example. Let's say that we have a diabetic with a laceration. Type 2 diabetic on insulin, has a laceration. We already have edema going on. Is that a complicated patient? Absolutely. Would you say, and with the laceration, are you just going to repair it? Sure. Okay. And we're probably not going to transport, correct? Okay. Let's say, do you do A1Cs? No. Okay. You do glucoses, though? Correct. Yes. So let's say, would you check the glucose on that patient while you were repairing her?
I generally ask if they've checked it today or not, and if they've checked it recently, I don't recheck it.
Okay.
If they haven't, then I do.
What if you check it and their glucose is 250? What are you going to do then?
Tell them to take their insulin.
Okay. Does that complicate the case?
Sure.
Does the higher acuity go up? Are you going to worry about cellulitis now? Do you see how that one patient that was not complicated or maybe mildly exacerbated just went to severely exacerbated? Now, I'm not, in that example, I'm not saying for you to document all of that. As a clinician, if you think it, document it. If you're not worried about the patient, that's fine. That's that is a moderate complexity patient. If I were auditing that record, and depending on what else you documented, that could probably be severe. So what if, let's just do, what if she already had an amputation on one of her legs? Then that would absolutely 100%. So that's why that history is so important to the auditor. So we call those status codes. In that history, I want you to tell hospitalizations, BLE, tell me that. Long-term use of insulin, tell me that they're on insulin. If they're oxygen dependent, all that goes in their medical history, okay? So she went to do a laceration repair, but she used the diabetes in her medical decision making. On her claim, she's going to report laceration in the diabetes because she used the diabetes in her medical decision making. So while you're going out to the case and you're just going for the back pain or just going for the laceration, if that patient has any other comorbidities that you use in your medical decision making, guess what? What happens? You have to report it on the claim. Active treatment of any condition that the patient has that you participate in has to be reported on the claim, 100%. Probably not the best example for community medicine, but I think it's going to start playing a role. Patient goes into the primary care office and it's a diabetic and they just get their metformin and they also need a refill on their Flonase. Easy for the provider, Flonase, script refilled. What is happening now with medicine is that Flonase prescription, when it gets to the pharmacy, the insurance carrier sees that. And then they go look at all the claims and say, this condition was not actively managed. What do you think is going to happen? They request the medical records. It can go both ways. So that's why the very first few sentences that I discussed is part of my role is clinical documentation improvement. That is clinical documentation improvement, okay? A lot of your patients have neuropathy. You are using neuropathy all day long in your medical decision making. Report the neuropathy. Even though you're not prescribing it, you're using it in your medical decision making. Okay, so that this slide does that, and then the management options. I think you guys do a very well job with your management options. You could expand it just a little bit. If you have, so we have the diabetes, the laceration. I'm going to throw in COPD right now. For each one of those conditions, I as an auditor would like to see a plan for each one of those conditions. Do I see for the suture repair, keep dry, warm, follow up with PCP, take meds as prescribed? That'll fly. I'm not going to tell you, but I'm going to tell you, for the auditors now, they like to see a plan. Don't make them work for it. When you're done with a patient, do they get a clinical summary of the visit?
No.
They do not?
No, we're working on it.
Okay. I'm not going to tell you my age, but I can't remember I take my children to the pediatrician. I go to the provider. I'm like, Trace, did he say this, this, or this? So for community medicine, this is why I'm very interested in. I would like to work on this. I'm going to see if that's a requirement, how your contracts are being written. Regardless, I would absolutely 100% recommend that all of your patients have a clinical summary when they leave. When you go to the ER, do they all leave with their plan? I would think that would be something that should be expected in your organization as well. Recommendation, I don't know your rules in Arizona, but I will make a note to look that up for you. So with the management options, the auditor is going to give you points for every management option that you list. So ICE, Tylenol, OT, PT, if you're doing that. You get follow up with your PCP as a plan. Take your medication, rest. Rice, all of that is a plan. So back to paint the picture of how sick the patient is. Also, everything that comes out of your mouth, if you can document it, you're golden. MDM stands for medical decision making, and this is data points. This is more auditor talk, but I would like to review it. Data point is anything that you do to the patient that we count. The pulse ox, the glucose, the EKG, anything in the medicine section, radiology section, all of those we give you points for. And one of the records, I love this case, this is one of my favorite cases. You went to went out on call, the patient was paraplegic, had dementia, was being taken care of her husband, had a Folian, was infected. The provider called the urologist, tried to help to get the Foley changed, was asking, they were consulting on the patient, what would be the best, what we should do for the patient. This provider, is the provider in the room about this patient by any chance?
No, but I know who it is.
Okay. That documentation was beautiful. As an auditor, you get the most points for that high medical decision making when you consult with another medical provider. Whether it's an MD, DO, PA, NP, it does not matter. When you talk back and forth and consult on a patient, absolutely document it because when I am auditing you, I'm going to give you 2 points right there. That 2 points pretty much just knocked you into high medical decision making, which this patient was. I really didn't even need to see that because it was already a high decision because the patient was transported. But do you do that a lot of times? And probably don't document it because you don't think it's important? Document it. It's very important. And it cements the risk, the acuity, the medical decision making of your case.
Do you have a suggestion
Her question was, where would she document the conversation with the PCP, the specialist, the surgeon, discussing the patient with the patient? Anywhere in the note. Typically, it's in the assessment plan. Sometimes I see it in exam, but in the assessment plan would be great. So her question was that when she is reviewing, and you have the actual, is it the patient telling you the information, or you have it in your hand?
The discharge summary from the ER, yeah.
Perfect. You have it in your hand. As you are reading it, even though that it says, let's say it's a CT normal, if you put review discharge summary dated September 25th, 2016, CT normal, that's you summarizing the discharge summary, you get full credit, you get that 2 points right there.
So it doesn't actually have to be the films? Or
Nope, it does not. Does not. As long as that, whatever you're reading from and summarizing has been signed off by another physician or provider, it's golden, okay?
So if it's in the chart but not in
It's a great question. So she asked if you do a glucose on a patient and the value is 110, do the providers get credit for that? Absolutely. Auditors, though that they're medical trained, we know value levels. We can assume that that is a normal glucose, and we give you credit for it. What happens if it's completely blank, you don't get credit and we can't give you credit. So anytime we call it point of care testing, if you do a glucose strep, iStats, you do, always give the result right there. Your pulse oxes are beautiful. EKGs are wonderful. You know, normal sinus rhythm. If it's not abnormal, tell me. And then you did also send me the printout. I couldn't read them because it was blurry, but that does count. But if that goes with the medical record to the auditor, that is fine as well. But I would tell you that anytime you do a point of care testing, whatever it may be, put it in your assessment plan of what the results are. And it could be 1 or 2 words: normal, abnormal.
So the results have to be there.
They have to be in the medical record, or in the case of the EKG, if you send me the strip, and I can see the strip usually has what the results are on there as well, I will take that, okay? It's just easier. So like I said before, you are documenting for the provider coming in behind you. Don't you think it would be easier that if Shar is looking at a record that you saw yesterday, instead of Shar going back and looking for the tracing, that it right be there in the assessment plan so she knows immediately what to do? I think we went over this already. This is your medical decision-making risk. And in this table, for you to qualify for one level of service, I only need one box checked in this box. So if you have prescription drug management, which would include your injections or amoxicillin, whatever it may be, you already have moderate complexity, which is a 214 or a 204. But that's just this table. The data points also play a point in that, and that's why I was talking about when you are those 2 points when you're talking to another provider. If you're doing the A1C, you get a point for that. Okay, and then I went back to the next step was when I was talking about when you list your ICD-10 codes, that you want to list every single one because the auditor is counting how many. So those 3 elements of medical decision making make up your final code selection. Any questions on that? Because sometimes that's confusing. And the reason why I say that, when I'm educating providers and I say, in this box, if you prescribed amoxicillin, that is moderate complexity, that's a 99214 or 204. I'll go back and audit him next week. All his otitis medias and sinus infections are 214s. That's not what I meant. He has to have the data points and the other ICD-10 to go with it. Here's a little trick that I train. If you remember 421, a 421 history will always get you a 99214 and below. So that'd be a 214, 213, everything below. This includes your home visit codes as well. So 4 elements of HPI would be location, duration, modifying factors, context. Typically when you arrive on scene, before you even say anything, that patient probably just gave you all 4 elements. 2 review systems would be any fever, any vomiting, chest pain, you got it. And then 1 past family social history would be allergies, but that's for 214 and below. A lot of your since you're seeing new patients, you're billing a lot of 204s and 205s. Those are going to require comprehensive histories. So if we have that patient that we'll go back to the diabetic that has the laceration, that's high. Actually, I'm going to use the Foley patient. The Foley patient is high. For the data points, he called the provider. He also changed it, so he actually got points there. And I only need 2 of those, so 2 out of 3, I had it right there. I could stop counting. Does that make sense how to use that table? You will not use this table. This is an auditor table. I just wanted to show you how they get to it. Transitional care management. I will start that medicine is changing. It's going to quality-based. As you all know, in 2019, the healthcare industry is changing dramatically, going from fee-for-service to what we call quality payments. So everything that you're doing now, CMS is collecting data on you for those patients. So that's why I stated that if you are treating a condition, code it to the highest specificity. The transitional care codes were created in 2013 because what is happening is patients are being readmitted over and over and over again. And when a patient is readmitted, healthcare dollars, or payers have to pay more money, the hospitals have to pay more money, the patient has to pay out more money. That's not a win-win situation. So what's happening now, hospitals are penalized for patients that are readmitted. If a patient is readmitted, they do not get paid. You have a grant for this program, which that speaks volumes of how your community is reaching out to you to improve the quality of care to your patients that is being delivered. So for that patient with the Foley, she had already been, I think she was discharged 2 days ago. They called back, guess what? She was going back to the hospital. Now, let's say if the day that she's released, she was seen the very next day by a provider. Do you think maybe we could have caught that infection before it started and maybe make sure that the Foley was inserted correctly, that she was on antibiotics, and we could have stopped her from being readmitted? That's the whole idea of transitional care management, is the day the patient is admitted, ideally that they are seen within they are made contact with a medical provider within 48 hours, because if Shar calls a patient and says, hey, Yvonne, you're discharged, how you doing? That patient's going to give Shar a lot of information like, well, I can't even get out of bed today. Well, Shar's going to know right away something's up. Or she knows. A non-clinical person, that may say, well, how you doing, Yvonne? Well, they told me to take a pink pill. Well, that means nothing to someone that's not clinically trained. So with the grant, I highly recommend that your organization adopt this. You get your superiors involved. In the state of North Carolina, we have care coordinators that just do transitional care management for our organization. We place people in throughout Raleigh-Durham Medical Group. Well, I work for Intermedix, but the group that I'm working with is Raleigh-Durham Medical Group, and we have care coordinators that literally sit there, go into the databases of each hospital system and look at each physician and see who was admitted, who is discharged. As soon as they see the discharge, they pick the phone up right then and there and arrange for the patient to be in the PCP's office the next day. They even arrange transportation if that is what is needed. I just went over what the requirements were. I kind of basically said them already. Like I said, you have my card if you have any questions. And then your grant, whoever doing the grant will absolutely give you the instructions how to implement. Procedures, this is going to be pretty easy. You do repairs, infusions, catheters, fluorescein. So we were talking about infusion. Shar was telling me that your intent for infusions is not for hydration.
No, it's only for hydration.
Oh, only for hydration. Okay, you just strictly do hydration. Every now and then you will push Zofran, correct? Okay. So just when you are documenting your infusions, and I can see a beautiful little box there, you do have to have start and stop times for your infusions. So, and I believe MediaTouch does have a spot for you to add that. I'm going to tell you, like I told the ladies yesterday, absolutely do your start and stop times for your pushes as well, okay? I'm not going to go over in great detail, but the intent of the service, so their infusion codes are based on hierarchy. One does pay more than the other. It is all based on your intent. So if your intent is to get the Zofran in first, and you're going to hydrate, then the push is the primary. If it's hydration only and you're not pushing anything, then the primary code will be hydration. Self-explanatory in here. The CMS MAC for your state typically will have what they want you to follow for intent for infusions for most major procedures. So I would absolutely, I believe I already sent, I was looking through some old emails yesterday for preparing for MESA, and I did have that in there, and I will forward it to you guys again.
So I know, like in the ER.
So she was saying in the hospital setting, she said if they're doing infusion, they push 1 or 2 or 3 drugs, they list those in sequential order. So that probably is a CMS rule for your state. So that's what you would follow, absolutely. Yeah, he said a patient had a PICC line put in, and when he was called out, he was just making sure that everything was flowing through, it wasn't infected, no clots, and asked if there was a CPT code to report that service, because that does take a lot of time for him to look at it. There is not. It would be evaluation and management code, just for strictly reviewing that the PICC line is still working appropriately. All right, nasal hemorrhages. So a lot of times patients come to you from the ENT, wherever they may come, and they're packed up, and you're called, and you remove the packing. No longer bleeding. You will report an evaluation and management code, because you're not going to repack it. It's evaluation and management code, and there's no global period, so you are allowed to bill for services. How we brought this up yesterday is, even if you think that a procedure has a global period, that as clinicians, that's not your job. That's billing's job. When you go on site and treat a patient, you are not to think if you're going to get paid for that service. Your job is to report the service, bill it, and let us worry about it on the back end. Okay?
And then the diagnosis code for the epistaxis.
Great question. Right. So we go to the next. Oh, so actually go back. So obviously when you take the packing out, they're no longer bleeding, correct? So your ICD-10 is still going to be the hemorrhage. But the second ICD-10 code, and I apologize that this is little, it's the follow-up codes are used to explain continuing surveillance, following completed treatment of a disease, condition, or injury. So after the nasal hemorrhage, you're going to use, and I believe it's Z09, which states that the patient did have a nasal hemorrhage, it is cleared, you remove the packing. Then the insurance company knows that nothing else is going on. Pediatricians use that a lot for otitis media, etc., for self-limited conditions.
What did you say the second code was?
I don't know them off by heart. It's Z08, 9, and Z39. I believe one of them is history of cancer, that if a patient has breast cancer and they had a complete mastectomy, then I think that's the Z08. Do not quote me on that. I would have to look it up, but I think that is history. So why a patient has breast cancer and they had a complete mastectomy, even though the patient is in remission, cured, as providers, you are still thinking about that. Is that a good way to explain it?
Yeah. It's just, I mean, I'm one of the ones that asked.
Anytime you're treating a patient, I'll go back to, you document everything that you did, report the code that you think that is applicable for it. If you have any questions, you can reach out to me. But for this example alone, there is not a CPT code for it. It is evaluation and management. So we talked about how we're going to, with your billing and stuff, but continue to do exactly what you're doing. Every service procedure that you do, document, find the most appropriate CPT that is applicable at that time, and report it.
And then you will.
So Shar asked me, that would be Intermedix, your billing company, right? Will Intermedix be adding CPT ICD-10 codes to your claim? Absolutely not. They are not clinicians, okay? That is the sole responsibility of any provider in any organization. So that's how we talked about maybe we should get a biller, a coder on site to review some of those things. Now, with that being our claims editing system will catch errors, and they're like, if we need a modifier, sometimes it'll catch it. But you do not want to rely on the editing system because it's a computer again, okay? it will catch if you use an ICD-10 code that has been deleted. It'll catch very common, easy, high, or low-level errors, should I say. But do not rely on the editing system in Intermedix to catch errors. So I just looked at some of your medical records. When you are searching for a code in the EHR, in this particular case, she gave the patient oral Flexeril. And of course, you know, she wanted to make sure that they swallowed the Flexeril. Understood. She picked a code that is H0033. When I looked the code up, it states that the patient took methadone.
It states oral medications given and observed.
Right, but and then auditor talk, it has a layman term that says methadone. So I talked to some other auditors. I would refrain from reporting that code, but then I'm going to go back to your MAC. Your MAC may say that is acceptable. Community medicine, again, is a different territory. So the wonderful thing about this being a paving the way is you're going to be able to write a lot of the rules. If this was primary care, I would tell that primary care physician, stop reporting that code. What you could do for the Flexeril, what I would recommend at this time is still document, observe patient taking the Flexeril ingested. So her question is, if you give Rocephin does have a HCPCS code, J0696, you're given 1 gram, which goes in 4 units. You're absolutely right. That code by AMA has a description. Flexeril does not have an injection for oral, what I'm saying is there's no code to report to the insurance company to say that you gave oral Flexeril. You're going to have to use a generic code.
Or Tylenol.
Tylenol.
Or
All of those, a lot of the Tylenol, Flexeril, Benadryl, all of those, if it's not injected, if it's oral, there is no code to describe it at this time. So what you would have to do is report a unclassified drug, which is J3490, and then on the claim you'll put a description that Tylenol, 200 milligrams, Flexeril, 10 milligrams. Then it's payer discretion if they're going to pay it or not. I understand that you did pay for that medication. You would like reimbursement just like the Rocephin. That is a payer-specific rule. In the state of Arizona, I don't know what your rules are, but I'm assuming that it's the same all over the United States, that you're not going to get paid for it. Depending on if you're facility, non-facility. Now hospitals, they do get paid for $2 for that Tylenol. It's in their contract. So NDC numbers always, absolutely, for any drug that you administer orally or inject, has to be in your medical record. And I think that's comments, information. I have the dose, unit, route, size. I would put NDC number, where it is going. On the comments, maybe we can put unlisted code. Also, so this is a 99203. We have we injected the Toradol. There's actually, you're missing revenue on here. I know this is not to be about charge capture, but anytime you inject a medication, does anybody want to tell me what that code would be?
I don't know the code, but I know it's an injection code.
Right, 96372. Please report that. That is revenue. It pays around $30 to $50. And it just means that you injected a therapeutic or antibiotic injection into the patient. So this would be a loss of revenue if it was a charge capture audit, but that's not the intent of the training today.
And it's the same one whether it's IV or IM, right?
You got it. Her question was, 96372 would be the same if it's IM or sub-Q.
hold on. To go
I
back
meant
to where we were doing
IV.
Sorry.
I'm sorry. No. Okay. I'm glad you.
It's the same, but IV.
I'm sorry. No. IQ. IV is not 96372. So I'm going to rephrase all that. 96372 CPT code reads that you injected either IM or sub-Q a medication. IVs have their own set of CPT codes. So she said she started an IV the other day and she had no idea what CPT code to report. This is going to go back to your MAC, but I'm going to tell you how it's done most. As a medical provider, since you started that IV, it is included in the infusion package, okay? There are CPT codes out there for starting an IV. They are listed as 36000 code series. You have to go back to your MAC and see if, I'm going to go into a little bit of code talk. It's called a CCI edit, which is Correct Coding Institute. Your payer may not allow you to bill the insertion of the IV and the surgical package together. Some may allow both codes to be reported and paid.
Okay, so if I put in the IV to give fluids plus I'm giving the other meds, it's just automatically included in the whole package?
Correct. So her question was if she's given an IV and you're pushing a drug, did you say?
Yeah.
Yes. It's all included in the surgical package. You cannot bill the 96372 in addition.
What was the surgical package code again?
When I say surgical package, is what I'm saying is infusion is considered a surgical package.
Sort of a suture package.
I know where you're going. So whenever you do a surgical package, which is, to me, a surgical package is infusion, repairs, any procedure that you do that's not E&M related. For surgical packages, there's another charge capture code that you can report. It's called A4550. That it reads surgical tray. So the patient with the Foley, that provider could have reported that he used a surgical tray to change out the Foley. When you do a repair, you can report it. Disclaimer, not all payers, it's payer specific. Some may bundle it, some may pay it. So just have to put my disclaimer out there. So this was just a patient that was coming in. We have the diagnosis of muscle weakness. So this is a 99203. He's telling me right here that he performed and interpreted. Usually when you if you do it, interpret it, and document it in report form, and the report form could be EKG, normal sinus rhythm, that is considered a report. It's not appropriate to split it if you're doing a global service, okay? But as providers, you are performing it, reading it, interpreting it, and then documenting the results. Then that is a global code. What we see here, it is not, you're reporting it as two different things. You're reporting that you performed it, and you also, so basically is what you're saying that you interpret it, but there's no results. Okay? So interpretation only, well, if you're interpreting it, then a report. Yeah, okay? And the other reason why I did this is in 99203, if you read the note, this is a very sick patient. I think I might even cut off some of it for HPI reasons, but he's using drugs, and so we use that in your social history. I hope this was helpful. Any questions? Just as I stated earlier, I'm very interested in this program for several reasons, but feel free to reach out to me. I usually try to get back to providers within 24 hours, and obviously I travel a lot, so sometimes if it's a coding question, I do have a team of 3 auditors that I would send the question to, and you might get an answer back, and it might not be from me, but it'll be one of the auditors.